The topic for this lecture is traumatic brain injury. A traumatic brain injury is any alteration in brain functioning or other evidence of brain pathology that's caused by an external force. Traumatic brain injuries are head injuries, and they are the result of any physical damage to the brain. There's two categories: open head injuries and closed head injuries. Open head injuries involve injuries in which there's a penetration of the skull into the brain, and closed head injuries are caused by movement of the brain inside the skull. So any sort of a force that causes the brain to slam into the inside of the skull, like an automobile accident, a fall, or a severe blow to the head. Examples of open head injuries include things like gunshot wounds or stab wounds. In an open head injury, it's not unusual for other things to enter the brain as well, such as bone fragments, hair, and skin. 1/3 of all injury-related deaths are brain injuries, and the number one cause of traumatic brain injury is falling. Open head injuries are any injury that involves penetration into the skull, and of course the most famous example is Phineas Gage. And the severity of an open head injury is dependent on the areas of the brain that are affected. The most severe open head injuries involve both hemispheres and/or the ventricles or multiple lobes of the brain. And when that happens, those are usually fatal injuries. The total of all medical costs related to traumatic brain injuries in the United States is estimated to be $781 billion annually. And there's been a huge increase in the number of gunshot wounds to the head in the last 20 years. In fact, it is the leading cause of traumatic brain injury in many urban areas, and it's the leading cause of death for those between the ages of 25 to 34. And a gunshot wound to the head is fatal about 90% of the time. If you do happen to survive after a gunshot wound to the head, it's likely that you'll have epileptic seizures and require medication for the rest of your life, in addition to having cognitive, motor, sensation, emotional, or other disability. Assessment of head injuries is conducted with a scale called the Glasgow Coma Scale. And this is a neurological scale that was designed to objectively assess the conscious state of the person for treatment. So it assesses the state of that individual's central nervous system. And there are 3 different categories that are rated using the scale, including eye-opening, verbal response, and motor response. So the higher you score in this scale, the better off you are. The lower you score, the worse head injury that you've sustained. EMS use this, doctors, nurses, and also people who are in the intensive care unit use this to monitor patients. Closed head injuries, more often called concussions, are milder traumatic brain injuries than open head injuries. And they're usually caused by a blunt trauma or a blow to the head. And even if there's not a blow to the head, a concussion can be caused by a jolt to the body that causes the head to suddenly move, like a bomb blast or a car accident or a tackle in football. Concussions are referred to as mild brain injury because a concussion itself is usually not life-threatening, but they can range from mild to severe enough damage to the brain to cause coma. A concussion is a serious brain injury. Even a mild concussion is a serious injury. Most concussions don't involve a loss of consciousness. And even if it doesn't involve a loss of consciousness, it is still a serious injury, despite the fact that sometimes people refer to a concussion as getting your bell rung or getting dinged. And concussions can also happen with an open head injury as well. They aren't limited to closed head injuries. Symptoms of a concussion include a stunned or dazed appearance, confusion, mood and personality changes, loss of memory, movement problems so that the person becomes clumsy or has balance problems, photophobia, which is sensitivity to light, vision disturbance such as blurred vision, headache or a feeling of pressure in the head, nausea or vomiting, unusual sensitivity to sound, or even just a sense of not feeling right. And sometimes those symptoms are apparent immediately, but sometimes they can have a delayed onset for hours or even days after the injury. With a single concussion, most people recover relatively quickly and fully. The usual recovery process is about 10 days, plus or minus a few days. But for some people, the recovery process can take much longer, even weeks. Concussions occur fairly often in the United States, 128 out of every 100,000 people, and young children have the highest rate. And most of those accidents in young children are caused by sports and bicycle accidents. The most common cause for adults, as I mentioned before, is falls. Concussion involves a blunt force trauma to the head. In this picture, you can see that the blunt force is caused by a baseball bat hitting the front of the head. And the place where that blunt force hits that causes the skull to smash into neural tissue is called the coup. Sometimes the force of a concussion is so strong that after the initial impact, it causes the brain to bounce back to hit the opposite side of the skull from the coup. And it creates a secondary area of damage, and that's called the counter coup, or you can pronounce it contra coup. A severe coup or counter coup can also cause bleeding to occur, and this bleeding happens underneath the dura mater, so it's called subdural, which means underneath the dura, hematoma, which is bleeding. White matter injury can also be a result of head injury if the skull violently moves faster than the brain. This violent and accelerated movement causes a tearing and a shearing of brain tissues and axons, and if this is severe, it can result in permanent damage. This kind of damage can also occur without a focused area of severe damage caused by a blunt force. This is the kind of damage that shaken baby syndrome causes. After the mechanical or blunt trauma-related damage, secondary damage to the brain can also occur, and this is damage to brain tissue that's a result of the changes in the brain that occur after the traumatic brain injury, such as changes in blood flow, in oxygenation, and inflammation. After the initial traumatic brain injury occurs, within milliseconds, there's a sudden release of neurotransmitters as the brain attempts to restore itself. It starts a neurochemical cascade that includes the release of neurotransmitters such as glutamate, which leads to excitotoxicity. Other changes in the brain include swelling or edema, and that swelling makes things worse because it increases the pressure inside the skull. And that makes blood flow even more difficult. And all of these things together can have devastating effects on the brain, causing more brain tissue death. There aren't any drugs that have been shown to be beneficial in preventing these secondary effects of TBI, but one thing has shown some promise, and that's inducing moderate hypothermia, or cooling the brain. Cooling the brain is one way to reduce and slow damage to the brain, because moderate hypothermia actually protects against many of those changes that occur because they are highly temperature sensitive. And the rate at which they damage the brain slows down considerably. That means that the injury due to lack of oxygen and glucose to the brain and from excitotoxicity that causes the destruction of cells slows down considerably as well. And that also reduces the inflammation and swelling due to the injury. So cooling the brain and inducing moderate hypothermia may improve the devastating effects of traumatic brain injury. And so research is continuing on hypothermia as a treatment for TBI. One of the most difficult aspects of treating concussions is the fact that damage is not usually apparent using a CT or an MRI. A CT is essentially an enhanced X-ray, and an MRI uses pulses of radio wave energy to produce a different image with a little better resolution. Neither of these scans are able to identify white matter damage to the connections between the brain. So although CT and MRI are useful because they can help identify subdural bleeding or skull fractures, they aren't able to identify concussive damage because damage in concussions is a result of stretching, tearing, and shearing of those connections between structures in the brain rather than damage to those structures. Diffusion tensor imaging, DTI, is a relatively new method of brain imaging that uses MRI in combination with software that allows the connections of the brain, or the white matter, to be revealed. And because it can show damage to the connections between the structures in the brain, it provides a way to identify damage of the axons and the white matter in concussion. The image on this slide shows the results of a DTI scan, and the area circled in yellow indicates damage to the connections in the frontal lobes, an area that's often thought to have sustained damage in concussive injuries. One of the complications of concussive injuries, also called mild traumatic brain injuries or MTBI, is that sometimes people can develop post-concussive syndrome, PCS, a constellation of cognitive and emotional symptoms that can lead to chronic disability. PCS can develop a few days after the concussion, and it can include memory and concentration problems, mood swings, headaches, fatigue, dizziness, drowsiness, and insomnia, and those things can persist for weeks or months. Recently, they have started to believe that this illness may occur because the concussion disrupts the pituitary gland's ability to release normal amounts of growth and sex hormones, and places in the brain that require those hormones for normal functioning suffer as a result. The structures that rely on these hormones include the amygdala, the prefrontal cortex, the putamen, and the hippocampus, and because these structures are so important in cognition, mood, sleep, and memory, it leads to dysfunction in these areas. The upside of this research is that PCS may be treatable simply with hormone replacement therapy that can help alleviate those symptoms until the pituitary gland could heal, and that would provide a needed treatment for this syndrome. Another complication of concussive injuries is second impact syndrome. And this syndrome is somewhat controversial because it is very rare. Only 1 to 2 people die each year from this. So some have speculated that it isn't even a real syndrome. However, most medical professionals believe this is a real medical issue that people need to be aware of. This syndrome has a 90% mortality rate, and it's believed that after a concussive injury, death occurs as a result of uncontrollable and fatal brain swelling that results from a second concussion that is sustained before a first concussion heals. After the first concussion, the brain becomes more vulnerable, and it loses its ability to regulate pressures because it is engaged in the healing and recovery process. And when a second concussion happens before that healing is complete, death is caused by increased intracranial pressure, which happens very quickly, within 2 to 5 minutes, because of the brain's inability to regulate pressures. And this is difficult or impossible to control. This picture shows a young man named Cody Leahy who suffered from second impact syndrome. While in high school, he suffered a mild concussion during a football game. He didn't feel normal, he was pulled out of the game, and he went to the doctor. And the doctor had a CT scan done, which appeared normal because concussive injuries aren't visible with CT scans. And so the doctor cleared him to return to practice. And Cody returned to practice despite still feeling concussive symptoms. While in practice, he was unfortunately hit again, and he was able to make it to the sideline of the field before he collapsed. But the increased pressure in his brain from the second concussion resulted in permanent damage, and he is no longer able to walk by himself and is permanently disabled as a result. The highest risks of second impact syndrome occur for boxers, football players, hockey players, baseball and basketball players, and snow skiers. And as I mentioned, it's a relatively rare syndrome, but it's strongly advised that any athlete who shows signs of a concussion should not be allowed to resume playing the sport and should only be allowed to play when he or she is completely asymptomatic. Kids younger than high school are playing hard-hitting tackle football as well. In the United States, 3.5 million elementary and junior high school kids play tackle football. The first study examining head injuries in kids playing tackle football was just published. They embedded accelerometers in the helmets to measure the impact of the hits that they were sustaining to the head during practice and during their games. The average 7 to 8-year-old experienced 107 hits to the head in a 5-game season. And most of those hits were modest in force, but some topped 80 Gs, similar to some of the more severe impacts that college players experience. Most of these high-level impacts happen during practice. So the authors of this study call for the elimination of high-impact hitting drills that don't simulate game situations at practice. One of the main issues is that young athletes in the United States face a culture of resistance to reporting that they might have a concussion and to complying with suggestions that they be taken out of a game. If they report their symptoms, they face the stigma of not being tough enough to withstand having their bell rung or getting dinged, and they also don't get to return to the playing field. But even more worrisome are the parents of the child with the suspected concussion on the sidelines who insist that their child is fine, despite the recommendation of the trainer that they sit out, because they want to see their child play. Almost half of all high school players in one study reported suffering a concussion, and 35% of players say they've had more than one concussion in the same season. Unfortunately, the data on multiple concussions for high school athletes indicates that athletes who suffer 3 or more concussions during high school are 10 times more likely to exhibit multiple abnormal responses to head injury. Research indicates that having 3 or more concussions in high school results in abnormal responses to later concussions, greater damage, and more potential for permanent damage from head injuries later in life. And the effects aren't just limited to the physical damage. Athletes with 2 or more brain injuries in high school have lower GPAs compared to their peers who have not sustained concussions. What's becoming clear from the research is that multiple concussions increase the risk of long-term damage to the brain. In fact, recently, chronic traumatic encephalopathy, or CTE, has been in the media as an example of that long-term damage from repeated head trauma. An extensive study of athletes with histories of repeated mild to severe traumatic brain injury indicated a definitive link between head trauma and degenerative brain disease. CTE involves a progressive loss of cognitive abilities, problems with regulating mood, increased aggression, dementia, Parkinsonian tremors, and loss of voluntary motor movement, and eventually death. CTE is clearly evident by the degeneration and shrinkage of the brain that can be observed in an autopsy. CTE results in degeneration and shrinkage of brain tissue, as you can see in the bottom image, enlargement of the vesicles, and deterioration of neurons that include the presence of dense deposits of tau protein, the protein that results in neurofibrillary tangles. Not only is there an increased risk for developing CTE with repeated mild traumatic brain injury, there also appears to be a link with a specific genotype of the apolipoprotein E, or APOE, gene. Some alleles of that gene have been found to be related to a higher likelihood of developing this degenerative brain disease. And alleles of that gene have also been related to higher rates of Alzheimer's disease. So that genotype may make you generally more vulnerable to developing degenerative brain diseases. One interesting subject that was part of one of the first studies of mild traumatic brain injury and degenerative brain disease is the brain of an 18-year-old multi-sport athlete, only known as John Doe, who suffered multiple concussions. In the top left slide, you can see a small deposit of tau protein, and if you magnify it, as in the lower left box, you can see dense tau neurofibrillary tangles surrounding that area. This is an example of CTE and the effects of repeated head trauma in the brain, which can apparently begin to develop as young as a teenager. The mechanism for how these tau proteins develop in the brain is not entirely clear at this point, but probably has to do with injury-related breakdown of the tau proteins in the brain and the development then of those neurofibrillary tangles. CTE used to be called dementia pugilistica, and this was something that was associated with some boxers, specifically Muhammad Ali. You can see the before picture on the top and the later picture on the bottom. It's been called punch-drunk syndrome as well, and is thought to be the result of repeated head trauma. In the case of boxers, repeated blows to the head. Similar to CTE and athletes, not all boxers develop this dementia, and they're not really sure why, but it may have something to do with the apolipoprotein genotype. With the recent publication of League of Denial, the book detailing the extent that the National Football League tried to dismiss the effects of playing football on long-term brain health, the settlement of a $765 million lawsuit recently with former professional football players suffering from the effects of repetitive head injuries, and the publicity generated by pro football heroes such as Junior Seau, Mike Webster, and Tony Dorsett, who most likely have CTE, there's starting to be a greater awareness of the potential for long-term damage from repeated traumatic brain injury. And even for those players who don't go on to develop CTE, there appears to be a relationship between the number of concussions sustained and the likelihood of developing depression. The more concussions sustained while playing football, the higher likelihood of depression. It's not just athletes that are suffering the effects of concussive injuries. The war in Iraq and Afghanistan has led to a huge increase in concussions as a result of improvised explosive devices and the pressure waves that the blasts create when they are set off. Soldiers in the military are experiencing the highest rate of MTBI, of any 10-year period of combat in history. In 2011, 1,200 soldiers per quarter were identified with mild traumatic brain injury. This is partly due to the nature of the war with improvised explosive devices, but also it can be attributed to better rates of diagnosis on the battlefield and after returning from war, and also a greater vigilance by the military in identifying head injuries. Unfortunately, one of the problems is that a CT scan is typically done to assess damage, and the results are normal, which is not unexpected with concussive damage, since it doesn't show up with that kind of neuroimaging. As a result of this huge increase in brain injury, the soldiers that return who don't have visible wounds of war, such as amputation of a limb or some other wound injury, the ones that have traumatic brain injury don't appear to be injured. So traumatic brain injury is considered one of the invisible wounds of war. 160,000 soldiers have been diagnosed with mild traumatic brain injury since the start of the war in 2000. That's 15 to 23% of all service members. In fact, mild traumatic brain injury or concussive injury is now considered to be the signature wound of soldiers returning from war in Afghanistan and Iraq. And unfortunately, the effects of mild traumatic brain injury are intensified because many of those soldiers also suffer from PTSD, and that's made worse by the brain injury. This graph shows the dramatic increase in the number of traumatic brain injuries identified by service branch. You'll notice that in the years between 2005 and 2009, there was a threefold increase in the number of brain injuries diagnosed in the military. That may be partly due to the nature of the weapons and the blasts that increase the chance of concussive injury, but it's probably also partly due to greater vigilance and diagnosis of mild traumatic brain injury. Those soldiers who return from war with a mild traumatic brain injury often report experiencing post-concussive syndrome. One study indicated that 97% reported experiencing one or more symptoms from a concussion 3 months after the concussion occurred. In fact, some soldiers are returned to war and deployed, still experiencing those post-concussion symptoms. And unfortunately, despite the huge increase in the identification and diagnosis of mild traumatic brain injury, when soldiers have returned, the screening, treatment, and rehab services for those suspected of and who have been diagnosed with mild traumatic brain injury have been excessively delayed. Soldiers were even denied treatment for mild traumatic brain injury in some cases, especially if PTSD was also present. Add that to the stigma that's associated with seeking treatment. Soldiers are hesitant to admit that they have difficulty because it doesn't appear that they're wounded, and they want to appear battle-minded and tough and not affected by the war. But they are affected because suicide is now the leading cause of death for soldiers in the Army. In 2012, more active duty soldiers died by suicide than were killed in combat. And across all branches, right now, an average of 22 soldiers commit suicide every day. The researchers who conducted the first extensive study of CTE have suggested that soldiers are also prime candidates for developing that degenerative brain disease. It's clear that there needs to be a fundamental shift in the way we treat soldiers returning from war, and those who have been willing to put their lives in danger for our safety need to be better taken care of.